Okay, so last week with Dr. Hale, you guys talked about health insurance markets, how premiums were set, and issues surrounding that, correct? Okay, perfect. So all of those things kind of predated the ACA, so we're going to build on that today and talk about how the ACA tried to level the playing field basically for those issues. All right, so to set the tone, the issues leading up to the ACA were cost, access, and quality. We're going to talk about all three of those, just kind of in a different order. We're going to do access first, and then quality is kind of tied in at the end, and then we're going to head on to cost. Healthcare spending as percent of the GDP. Everyone knows what GDP is, correct? Yes? Okay. This lecture is going to require you guys to really interact with me a lot today, so go ahead and get prepared for that. As a country, where does the United States stand on healthcare spending? Just the spending part.
Extremely high.
Okay. So in comparison with the spending, what does our healthcare look like?
Extremely low.
Extremely low, right? So there's a disparity between those two. So U.S. spending is much, much higher than any other industrialized country, but basically we're getting very little in return. We have a low life expectancy, and our living years are of lower quality compared to other countries as well. Are you guys familiar with the Massachusetts study of 2012? Okay, someone tell me just a thing or two about the Massachusetts study.
What the ACA was based off of.
Okay, and so what was done in that study that informed the ACA? Anybody? Okay, so basically the Massachusetts study is the best you can get without doing another randomized controlled trial. Why would you not be able to do another randomized controlled trial when it comes to providing insurance for the population?
It'd be unethical.
Right, why is it unethical?
Because people need insurance.
Because people need insurance, right. So this study, insofar as replication, that's really not going to be possible. So just a couple of statistics here. With the Massachusetts study, there was a 2.9% reduction in mortality after expansion. For every 830 people who gained insurance, that was one death prevented. When you do the math, 16.9 million divided by 830, you get roughly 20,000 deaths that could be prevented. So, hence, incoming ACA. When we look at the uninsured rates, prior to the ACA, about 15% of the population did not have health insurance, right? That's roughly 50 million people or so. You guys should have talked about that a little bit last week. Yeah, okay, great. So in 2015, the uninsurance rate hit single digits at roughly 9%, which was the lowest in 50 years. So clearly progress is being made since implementation of the ACA. When we talk about quality, we know why cost is important when it comes to insurance, and we know why insurance is important. There are several research studies that have looked at preventive hospitalizations. So what would a preventable hospitalization be? Say you go to the hospital, you have surgery, the surgery seems to go well, you get home, you're not doing very well, you spike a fever, seems like you have an infection. What would that possibly be?
You could have gotten an infection during the surgery, maybe?
Right. So that could have been prevented, right? Okay, so this is kind of the premise of preventable hospitalizations. So there have been several studies that have looked at these hospitalizations. So you go to the hospital for something that should be fairly routine, and you end up not coming out. So you either die or you have to keep coming back for something that was preventable in the first place. When you look at the leading causes of death, the third highest, ranked only behind heart disease and cancer, is medical errors. Is anybody surprised by that?
Yes and no.
Yes and no. Okay. So not only is access to the provision of care important, but it has to be quality care, right? Because if you're not getting quality care, it's going to lead to these preventable hospitalizations, and you have this these preventable deaths as well. So the need to reform how healthcare is delivered to improve health and well-being of the population is also tied to cost, right? Can we provide more care and keep the same amount of healthcare costs? Is that possible? What's the impact of the ACA roughly by millions of people? We're going to go over this in detail in a second, but does anybody know roughly how many people were able to gain insurance through the ACA, through implementation?
Millions.
Millions, exactly. Millions of people. So can we provide care to millions of people who were not previously provided health care without there being a raise in cost? It's not a trick question. Right, it's not possible. So we have these issues around cost and access, but not just related to insurance, and also quality. That's not to say that providers are doing a bad job, right? They are doing the best job they can with the tools that they have. So they're not necessarily doing a bad job. It's just kind of the position that they're in. So healthcare reform. The Patient Protection and Affordable Care Act was passed, I should say 8 years ago, March 23rd, 2010. It estimated to extend coverage to 32 million people. That's not the number of people that that actually got covered through the ACA. This was their estimate. It included 10 chapters and 41 subtitles. We're going to get into a bit more detail about subtitles here later, and also 50 initiatives that were to be implemented. The price tag, $1.2 trillion through 2025 would be the net cost. Is that a high price tag? It is. But when you talk about extending access to 32 million people, that doesn't seem so bad, right? All right. So, and also what's interesting to note is while this was the cost, each year we have repeatedly come in under the estimate. So that's kind of rare.
I have a quick question.
Yes, ma'am.
What is CBO?
We are going to talk about that here in just a minute. Okay. How many of you have read the ACA? The actual ACA? Okay. Do you think it's super long? Like most policies? Right? Nope. It is about a third of a page. The meat of the ACA is about 1/3 of a page. You see these, or previously have seen these ads by politicians talking about, well, who's going to go through and read all this? It's so onerous, and why would we vote for this? Not actually, okay? So the ACA is more of a general guideline of what is to be accomplished, and it's not really telling you how to accomplish that though. So we're going to talk more about that here in just a minute. It's kind of a template. So healthcare reform was focused around two areas: policy to create access, which was your insurance market reforms and your Medicaid expansion, and then policies to control cost, which was your payment and practice reform. Okay. So on this chart, it's an estimate of those who gained insurance because of the ACA. This data is from the American Action Forum, and this is actually a conservative group. So this group wouldn't necessarily have an interest in trying to pad these numbers to make it look better for them, right? So on average, we're not going to look at the low or high, we're just going to look at the average numbers. About 20 million people have gained access to insurance since the implementation of the ACA. These are not necessarily all newly insured people. These may be people who were insured previously, but they were able to get better insurance at better cost through the ACA. So about 10 million have gained coverage under the Medicaid expansion. And again, we're going to talk a little bit more in detail about Medicaid expansion here in a bit. And about 6 million through the individual market. So this is the marketplace that you guys have heard so much about. You talked about it last week about buying insurances on the market, rating schemes, all of that type of stuff. Roughly 1 million through the employer mandate, which we're also going to talk about more in depth here in just a bit. Do you guys know kind of what the employer mandate is? Yes, no? I see some nodding, but no one is speaking. Okay, so the employer mandate is for any organizations that have 50 or more full-time employees. So the employer mandate does not apply to every organization that is out there. Okay? And about 4 million have been able to stay on their parents' insurance until age 26. I don't know how old all of you guys are, but I'm sure maybe some of you in this room are under age 26 and have been impacted by this. All right. So we're going to talk a little bit more about this green section here, the individual marketplace. So this is affecting roughly 6 million people of the population. So with this, basically the ACA changed how health insurance companies operate within their markets. They have to think about it. They had to do things very different than they've ever done before, right? When you look at these things, you have to think, why haven't they been doing these things before? They can't deny coverage due to a pre-existing condition, and we're going to actually look at a pre-existing condition list here in just a second. No lifetime limits on annual spending. They can stay on their parents' insurance through 26 years of age, and it sets a medical loss ratio of 80%. Previously, medical loss was 60 to 70%. So basically, medical loss ratio is saying that they can 80% of revenue collected has to be paid toward the claims. Previously, it was 60 to 70%. So the revenue that was generated, they were only using 60 or 70% of that to actually pay out claims. This said they have to do more than that. Does anybody read these and think, well, that doesn't make sense at all? Or do you read these and think, Captain Obvious, why have we not been doing this previously? Which one? Right. So take a look at these deniable conditions. Pregnancy. That's a deniable condition prior to the ACA. If you are currently pregnant, they would not allow you to get coverage. Does that make sense to anyone? No. Obesity. How prevalent is obesity in East Tennessee? Yes. Particularly child and adolescent obesity, through the roof, right? Okay. Mental disorders. How many people do you think suffer from mental disorders?
A lot.
Exactly. So with this exhaustive list of deniable conditions, it would seem reasonable to think that they're actually excluding more people than they're including, right? Why would they want to do that? They're an insurance company. They're supposed to provide health care. They don't want to pay for it. Right. They want to watch those dollar signs go up, right? So prior to the ACA, this limited roughly 1 to 2 million people. That's an astounding number. Okay. Health insurance exchanges. So these were designed to help people buy insurance on the private market. So they gathered all of these different private insurance companies and put them in one place. How do you think they got their buy-in? What would make an insurance company say, I want to be part of this market?
Increased profit.
Right, it all comes back down to money. So they receive an incentive for possibly insuring this more at-risk population. Because is it the at-risk population that's going to use the ACA benefits more? Or is it your moderate to high income people who are generally healthy? It's your at-risk population, right? Okay. Alrighty, so they created this marketplace to purchase insurance. It is the establishment of health insurance exchanges. They offered subsidies to lower income individuals. What were these subsidies, do you think? So subsidies were basically dependent on your income. If you could not afford the level of care that you needed, you were given a subsidy. And it averaged out to be about $272 per person. Well, in 2015-16, the subsidies ran out, right? That's no good. So these subsidies is what was provided to the insurance companies as their incentive, okay? So when the subsidies ran out, what do you think insurance companies did?
They raised their prices.
I'm sorry?
They raised their prices.
Yes, what else did they do?
Kick people out.
They kicked people out. What else happened? They left the marketplace because it was no longer as profitable for them. So they said, well, if I'm not going to be getting these subsidies anymore, then I'm not going to stay here in the marketplace and watch my revenues decrease. So the subsidies through 2016 were as a short-term incentive to get buy-in from these insurance companies. The marketplace is still stabilizing after that occurred. It's just stabilizing at a higher rate than what people expected. So the premiums are still, it's still doing what it was supposed to do, but the premiums are higher for the participants than what was expected at this point in time. So people bought into the exchanges. Basically, they got premiums that were artificially low. Essential health benefits. So these are well-intentioned, but we really have to be realistic about what this means. So the minimum level of coverage with preventive services that may not have been offered before. So this was a driver for increased costs as well. So if you increase the amount of covered people and you increase the coverage that they get, this should equate to better health, correct? Yes. So it shifted this financial burden to insurers, and what did they do? If the cost is more to the insurance companies, they're going to do what?
Raise their prices.
Yes, they're going to raise their premiums. Individual mandate. This is by far probably one of the most argumented, contested portions of the ACA. Very unpopular. So this basically said that if you don't have health insurance, you are going to accrue a penalty on your taxes for not having health insurance. So this is just something kind of to stew about. Is it the government's responsibility to make you have health insurance? And this is just something to think about. You're not going to get the answer here. Just something to kind of keep in mind. I don't know about you. Well, one, I'm a redhead, so I automatically don't like doing what I'm told. But for you guys, do you like being told what to do? Everybody kind of reacts to that weird, right? Do you like being told what to do by the federal government? No, not so much. But when you think about it, it's not so much about the people have an issue with what's being provided. It's the people having an issue with being told to do and not having the choice in it, right? Okay. So on your federal tax return, if you have not had health insurance for the previous year, you will have a penalty of 2.5% of your income. And I think it's the max penalty is about $2,000. If you don't pay, they withhold it from your tax return. The thing to keep in mind is not having health insurance is not a criminal or a civil offense. So it's not like they can come and arrest you for this, but they are gonna do a fine. Do you think that there are any exemptions to this individual mandate?
Yes.
I'm gonna have to get all y'all some coffee. We're gonna be super, super chatty today, so pipe up. I got nothing but time. Yes, there are lots of exemptions to this individual mandate, and we're gonna go over those here in a bit. Something else, does everybody file taxes?
No.
No, right? So you have this penalty built into this program for not having insurance, but it doesn't affect those people who don't file taxes. Who are the people that don't file taxes?
The ones who usually don't have insurance.
The ones who usually don't have insurance. What else? Who are those people?
Unemployed.
They're the most at-risk population, right? So they're the people who need the insurance the most. Would you guys want to take a guess at the percent of the population that does not pay income taxes? 43%. 43%. So just take that number and stick it in your back pocket. All right, so moving on to individual mandate exemptions. If you were enrolled in an insurance during open enrollment of the ACA, if you have been uninsured less than 3 months, if you don't have to file taxes or don't meet the tax threshold, so if you don't make enough income, if the coverage that is going to be provided is more than 8% of your household income, and if you are part of a state that didn't expand Medicaid. Did Tennessee expand Medicaid? No. We're going to talk more about that here in just a second. And then there is your employer-sponsored health insurance. So this is the employer mandate, and so this is for they have 50 or more full-time equivalent employees. That's what FTE means. Full-time equivalent means that they work 40 hours a week. They have to provide insurance for 95% of their employees. This affects only about 3.6% of all the companies nationwide. Okay. Yeah, so about 96% of employers have less than 50 FTEs. How many of you have heard that Obamacare or ACA is going to kill jobs because of this whole employer-sponsored health insurance thing? Yeah, a few hands. So if it's only affecting 4% of the companies nationwide, do you think that's the case?
No.
Nope, not so much. To be honest, there are people who lost their jobs because of this. Yes, because there are some companies who decided to either get rid of people or cut hours and cut benefits. This is roughly 6 million people that affected, okay, adversely. But this lever of the policy only affects about 4% of the companies in the U.S. So when you're looking at it as a strictly numbers game, you have to look at net gain, right? Yes, you're always going to have some loss with any policy or program that is implemented. When you look at this, the net gain is much greater than the 6 million people. For people who are in public health, those 6 million people mean a lot to us, right? So we're not trying to discount the adverse reactions that they have had to this at all. We're just kind of looking at the bottom number for the moment. Okay. With the employees or employer-sponsored insurance, roughly 10 million people gained coverage, and then there's about that 6 million that lost coverage, with a net of 4 million people. Again, we're not trying to dismiss these 6 million people that lost their coverage. They're real people losing their jobs and losing their insurance, which affects their families. But from a policy perspective, there was still a net gain. Do you guys know what crowd out is? Just want to take a stab, anybody? Or not? Okay. So companies don't want to bear this cost themselves, right? So when they don't want to bear that cost, this is the crowding out is when they cut those jobs, they cut those benefits, and shift that to Medicaid. Okay. So private sector employment. Going back to saying that implementation of the ACA is going to make all these people lose their jobs. Raise of hands, since apparently all your tongues are broken. Did Obamacare kill jobs?
You want to raise the hands for yes?
If it's yes, raise your hand. If it's no, raise your hand. You are not allowed to not raise your hand, people. If you're yes, raise your hand. If you're no, raise your hand.
Wait, the question again.
There are still some people not raising their hand. I am short, but I will stand up so you can see me better. If you think that Obamacare killed jobs, raise your pretty little hands. If it didn't kill jobs, raise your hands. Awesome. I think I got roughly 97% of my return, so I'm okay with that. Okay. So implementation of the ACA is this little dot here. Everything to the left in the red line is jobs lost before ACA, and prior or after that in blue is jobs gained. What do you see that line doing? It's increasing. Which is completely the opposite. Where do you think that these jobs were added? I think I heard it. What?
The medical field.
Yes, medical field, healthcare. Okay, so this is a great time to be in public health or health administration because this is so complex that they're going to need people like you guys to figure it out and tell them what they need to do. So it's really important to understand that a lot of stuff that you hear is just not true about the ACA on both sides, not just on one side. It does have its problems, yes, but there's a lot of stuff just isn't supported by empirical evidence. And as public health professionals, do we do anything without empirical evidence? No. Okay. Seriously, y'all need some sugar. Okay. So this is just kind of looking at the same thing. So the point being is that we've actually had job growth, we've had a decrease in unemployment, and things are the strongest that they've ever been. So how can this be better communicated to the general public to where they can understand this? Throw out some ideas to me. I don't have the right answer. I'm just curious to hear what you guys think. How can you go out in the population who is not made up of educated public health professionals and get this point across that things are actually much better than what it seems? Does anybody have any ideas?
Show them the graph so they can get them to explain it
Okay.
instead of explaining it to them, you know.
So kind of like a reverse classroom scenario.
Yeah.
I get that. Anybody else? Yes.
I don't really think you can unless you impact them directly. So you would need to expand care to everyone in order to get that point across them.
You know, I get that. As awesome and wonderful and polite as a lot of people I know are, when it comes down to it, it's what is in it for me, right? How am I going to benefit from this? And how am I not going to be harmed by it? So as a population, the people are kind of caught in the middle, right? Trying to figure out what's true and what's not true. So we're going to do, this is kind of a little bit out of order, but I want to give you a 2018 update. So how familiar are you guys with the repeal and replace bill?
Didn't work.
Okay, why did it not work? Well, first of all, what was it? It wanted to do what? Just in general, 2 sentences.
Get rid of the ACA.
Get rid of the ACA, okay. What else? And replace it with something else.
Yeah.
Hence the name repeal and replace. Okay, so what has changed about the ACA? With the repeal and replace, this would have caused a market destabilization. They would cut the Navigator program. Do you know what the Navigator program is through the ACA? Okay, so it basically provided this person, a navigator, that would help both the individual and companies kind of navigate through marketplaces and through the ACA to figure out what would meet their needs the best, okay? So basically enrollment support, that was going away. It would also reduce open enrollment from 12 weeks to 6 weeks. So you went from having this bigger time span to a much shorter time span in which to enroll for your insurance product. Healthcare.gov would have maintenance every Sunday. When do you think people are going to be accessing the internet the most? On the weekends. So this was a genius idea to close it down for an entire day on the weekends. It would also repeal the individual mandate. It would provide association short-term plans where the rules of the ACA do not apply. What do you think these association and short-term plans are? For lack of a better term, it's skimpy coverage, right? So it's this very limited coverage that is expensive. It's not really going to do anything for you, but you still meet the requirement. You have insurance, right? It eliminated premium stabilizer subsidies to the insurers and eliminated out-of-pocket hardship assistance programs as well. So all of these things combined caused or would have caused a spike in premiums above what we have already seen. So despite all of these efforts, the ACA still remains relatively stable. Enrollment in private market plans for 2018 has been 11.8 million compared to 12.2 in 2017. So yes, there has been a decrease in enrollment, but it's very slight. Actual estimates of lost coverage vary as well. So NHIS says about 100,000. Commonwealth says 3.2 million. That's a drastic difference, right? What do you think would be the driver for that difference in number? And again, no right or wrong answer, just what are some things that you think would affect those large differences?
Bias.
Yes, that's what I was thinking as well. Large amount of bias. Anybody else?
Bribes.
I mean, possibly. And then premium stabilization. So there has been quite an increase in premiums for subsidized plans. The silver plan, there's gold, silver, bronze, but gold and bronze have largely remained unchanged. So it's more of a stabilization across the three different types of insurance plans that are offered. So with the individual mandate repeal and your addition of this kind of skimpy coverage, this can equal the siphoning off of younger enrollees. How would that affect healthcare or the ACA? I mean, yes, we have here the full impact is not yet known, but how do you think it could impact? Just a couple of ideas. Think about risk pool.
So you're saying that if the individual goes down, so most of your individuals are healthier, so now you're gonna have a pool of older individuals who have more health issues, which causes it to go up.
Yes, exactly. And not just older, but also you have the more at-risk population of these people with lower income who may have more health issues as well. So all in all, it translates to increased cost. So kind of just wrap up, collectively the ACA remains relatively stable And it's been suggested that those who are benefiting really need the insurance and assistance, which is kind of the point in the first place, right? Okay. Medicaid expansion. So they extended eligibility to 138% of the FPL. What is the FPL? I'm sorry?
The federal poverty line.
Yes. So it's really an exciting time to be in public health, right? Because we can make such a difference right here. It's so dynamic that it's amazing the things that we can kind of get into and do. We have to figure out how to sit down in front of one another and have this respectful, open dialogue and come up with a bipartisan plan that takes the best of all options and puts it together. What is it going to take to make that happen? I see a couple of eye rolls. What do you guys think? I mean, is that possible? Can people sit down in front of one each other on both sides of the party, right? And this person says, well, I think this, and this is how it would work. And this person says, well, I think this, and this is how it works. Take the best ideas from all of those, put them in together as one, and come up with this amazing healthcare reform.
Not impossible, but highly unlikely.
Yes. I would say that it would take a huge leap. Yeah. So, expansion would reach about 10 to 12 million previously uninsured adults and children, and many states already covered at a higher FPL, particularly those for pregnant women and children. So what happened here? The states challenged this mandate for Medicaid expansion, and the Supreme Court ultimately said that this mandate would cause undue cost on the states, and the states didn't actually have to do it. They could opt whether they wanted to expand their Medicaid or not. Okay. So what happened when this Medicaid expansion was no longer mandated for the states? So you have these people over here on your right in the blue who are between 100 and 400% of the FPL that can be covered by the marketplace subsidies. Your people on your left are under, or they're between 0 and 48% of FPL. They're going to be covered by Medicaid because their income is low. What happens to the people in the middle?
Nothing.
Right, nothing. So without Medicaid expansion, you have this coverage gap. The problem with this, besides the fact that people don't have access to insurance, is it created this gap for those states who did not expand their Medicaid. This affected roughly 5 to 6 million people. This is basically the same information, just another way to look at it. So again, you'll see the Medicaid expansion states on the left, non-Medicaid expansion states on your right, and you see that roughly 19% of the people there in orange, that is your coverage gap for your non-Medicaid expansion states. Between 2013 and 2015, the ACA extended coverage to 22.8 million. These people gained coverage, right? Roughly 6% lost their coverage. And we talked about, or 6 million, lost their coverage. And we talked about those 6 million people earlier. But you still have a net gain of 16.9 million people that were able to now access healthcare that did not have access to healthcare previously. So the roughly 17 million is below the projected impact of 32 million, right? A lot of this has to do with some of the states not expanding their Medicaid. It also has to do with some people just aren't enrolling in the private marketplace, right? So the ACA has not reached its kind of full potential or full capacity or projected capacity, but 17 million is not a small number of people, right? That's still a huge difference. So this is just to go back same slide as before, but just to remind you of kind of where everything stands. So this is trends in insurance coverage. You will see employer-sponsored insurance has gone up a hair. It's mostly remained the same. But look at the uninsured. What happened there?
Decrease.
Yeah, huge decline in number of uninsured individuals. Okay. So we're gonna move on and go ahead and talk a little bit about costs before we take a break. So it's easy to enhance access, right? Or if it's not easy, is it easier to enhance access to coverage or is it easier to decrease costs?
Easier to increase access.
It's easier to increase access, right? Because we can come up with these awesome programs and ideas and go, yes, let's implement this. And coming up with the money is something entirely different. So, talking about the cost side, everything in healthcare is essentially about trade-offs. So, for the increase in access, there's an increase in cost as well. Why is there the increase in cost? If you're providing people with healthcare, what are they going to do?
Use it.
They're going to use it, right? So if they use it, that's going to generate cost. And those people that are using it are probably the sicker portion of the population as well, because they've not had coverage previously. But the ACA did include provisions to help control these extra costs. That's what we're going to talk about here in just a minute. Policy buckets, for lack of a better term. So we manage competition in the marketplace to help keep premiums low and enhance access to preventive care. And then there were also payment and practice reforms, where we went from a construct of volume to a construct of value. We went from providing just payment to we want to provide quality care as well. So by increasing the value of services provided, we can help decrease the cost. How do they do this? How can you increase quality and decrease cost at the same time?
Well, if you have better quality care, then you're
Mhm.
more likely to find out what's wrong or fix it instead of having to repeatedly go to the doctor and be like, hey, you didn't fix this, hey, you didn't fix this. So you'd be going less.
So also think about it from the insurance side of things, the people who are actually insuring, and think about their payment structure. If we attach their payment to the level of quality that they're providing, what are they going to do?
Wouldn't they increase the quality of care?
Yeah, they're going to increase the quality of care because now we know that their payment is attached to the quality that they provide. So if they don't have good quality care, they're going to get paid or reimbursed less. Again, it's about that bottom dollar. So they're attaching this payment and reimbursement in healthcare to the quality of care and the outcomes that it produces. We'll get in some more detail about that, but pretty much this was a whole fundamental shift in how insurance companies are paid, right? So the first policy bucket that we are going to talk about is controlling the cost. Okay. Oh, I forgot something. For payment, is anyone here currently in Dr. Hale's population health management class? Do you have plans to take that class? Okay. I should see everybody's hands going up for that class, right? So when it comes to payment and practice reforms, that is basically what his entire population health management course is about. I highly, highly suggest that you take that course. I don't know if it's required for you guys. If it's not, take it as an elective. it's great for applied learning. Great for applied learning. So you're actually going to see these things in action. All right, the ACA created new payment and delivery models. It is important to know these are not mutually exclusive of one another. They are very interrelated, and they play on one another quite a bit. There have been multiple complementary approaches. They tested new models for healthcare delivery. There was a shift in payment from volume to value. We invested in a system-wide improvement. So these types of models were around in targeted areas before the ACA, but the ACA really took the best of these models and put funding behind it. And so that's what was implemented. What do you think we mean by testing new models for healthcare delivery? You guys heard of state incubator programs? No? Okay, great. Well, we're going to talk about that in more detail here in just a second. But basically, state incubator programs is where the ACA provides funding and says, this is what we want to do. Here's some money. Figure out how to make it work. Have I lost anybody yet? Are you asleep? Are you awake? Oh, that's not good. You sound asleep. Okay, awesome. So system redesigns. The perspective of the actual ACA bill. This is that 1/3 of a page I was telling you about, okay? So the ACA is not a how-to manual. It's a what-to manual. Here is what to do. It doesn't tell you how to do it, but it tells you what you need to do. So it talks about value-based purchasing, which was roughly 4,000 words. It talks about innovation. Those are the state incubator programs. That's roughly 2,300 words of the ACA. ACOs. Do you guys know what ACOs are? Accountable care organizations. Okay, we're going to talk about those more in depth as well. But those are really driving change in the healthcare system right now. And those are roughly 1,500 words. And then hospitals, about 800 words. So the point is there's not a whole lot of guidance about how to do things. It just tells you what needs to be done, right? So implementation falls to federal agencies. The big one around healthcare reform is put to CMS, or Center for Medicare and Medicaid Services. From there, it's through CDC, HRSA, and AHRQ. So I don't know about you. I have to see things to really understand it. I can read the words, that's fine, but things like this, charts, graphs, it really helps me understand things a bit better. Because this is a complicated system, right? Okay, so the ACA basically told CMS, we're going to hand you all of this healthcare reform stuff. And on top of that, we want you to create a Center for Medicare and Medicaid Innovation, the CMMI, or the Innovation Center. Like they didn't have anything else to do and they had plenty of time, right? So this center provides funding for your state demonstration projects that are trying to figure out how you can gain funding to provide better care. And that's where these state innovation models come into play. They're also providing funding for accountable care organizations. We're going to go into detail about those here in just a little bit. There's also, they also wanted them to push these patient-centered medical homes forward. Have you guys heard about PCMHs? No? Okay. Well, you will in a lot of your courses coming up. We're going to touch on those today, but we're not going to go into a great amount of detail. So that's kind of the flow chart from top to bottom. Now from the side, the ACA said, CMS, we need you to really push this value-based purchasing. We're paying for quality, shared savings models, and bundled payments. And we're going to get into all of that here in just a second. But all of these combined are meant to lead to better health, better quality, and lower cost. Okay, we are going to take a brief 5-minute break. In honor of Dr. Hale, do some burpees, run some laps around the building, get a drink of water, and then be back at about 4 till. Sorry, I can't read. So Medicare has historically been FFS, which is fee for service, right? So they provide a service, they charge a fee, and they get paid that fee. But they're making a shift from volume to value. So not necessarily having a high volume of patients, but providing value to the patients that they see. Did you have a question?
No.
No, okay, you're just kind of stretching out. Gotcha.
Stretching.
So CMS is trying to get 90% of all payments linked to quality or value of care. Right now it sits at about 40 to 50%. So we're not there yet, but they're definitely well on their way and better than where we were at the fee for service model. Okay, for the Center for Medicare and Medicaid Innovation, also known as the Innovation Center. So they were testing these new payment and delivery models to lower spending or improve quality and to spread innovation. So these innovative ideas. So the structure for reimbursement around quality of care that is more efficient and saves money. So here's some of these new payment or delivery models proposed and kind of worked on by CMS. Who is CMS? Yes. Okay. So the pay for performance programs, which would be VBP or value-based purchasing. Your state innovation models, you will see that a lot of times abbreviated as SIM as well. Accountable care, so that's your ACOs, and your patient-centered medical homes or your PCMHs. So all of these were actually subtitles in ACA to control the healthcare cost side of things. So the first thing we're going to talk about is the pay for performance or your value-based purchasing. So these pay for performance was geared around your hospital readmissions, reduction of infections, and this value-based purchasing. So for the hospital, if you come back for any reason within 30 days, Medicare will not reimburse you for that subsequent visit, regardless if it's the same hospital or a different hospital. Now, just like anything, are there exemptions to this?
Yes.
Yes, there are. So saying if they come back for any reason isn't really correct. And we'll get into that here, I think, on the next slide. So, and similar for these second two initiatives with reducing infections and value-based purchasing. So hospital readmissions. There are certain conditions that CMS is really monitoring. These include heart attack or heart failure, pneumonia, COPD, hip and knee replacements. So, and why are they tracking these things? Are these conditions more likely to have a readmission?
No. Yes.
Yes.
Yes, exactly. Yes, they are. So if you have higher than the average admission rate, you will see a decrease in your Medicare payments across which admissions? All of them. Not just for these specific things, but if you have a higher than average readmission rate for these particular conditions, you will see a decrease in Medicare payment across all admissions. So again, that's 30 days for these select conditions and applies to any hospital, not just the one hospital where you had your initial visit. And the penalty, for lack of a better name, is adjusted for age and severity. So if you have excess rate, you have this higher penalty. So by 2015, this represented 3% of Medicare reimbursement is at risk. So Medicare reimbursement is a huge component of hospital revenue margins. What do you think hospital revenue margins look like? Come on, people, I know you can speak. What do you think hospital revenue margins look like? Do you think they're large? Do you think they're small? Do you think they're moderate? What do you think? They are very, very razor thin, roughly 4%. Okay? So when you have Medicare revenue that is such a big portion of this hospital revenue line, if that is cut by the 3% that's at risk, what is that going to do to hospital revenue? It's going to plummet, right? And it's already a very small margin anyway. Over half the hospitals already operate at a deficit, or they're in the red. In 2017, this equated to $528 million. 79% of the hospitals participating were penalized. So almost 80% of hospitals in the nation were penalized. What does that mean about their readmission rates?
They're high.
Right. But there's certain hospitals that are at greater risk, right? Depending on location. So some hospitals are at greater risk because they may provide more care to your low-income Medicare patients. Okay? So how do you try to ensure that people don't come back to your facility? What can you do to ensure that people aren't readmitted back to their facility? Do what? You have to speak a little louder. I'm deaf.
Proper care.
Proper care. Okay. Take that just a step further. What's kind of the really big push in public health when it comes to type of care provided, besides it being, having high value, high quality, starts with a C. Coordinated care, right? So if I were a provider, what I'm going to do is I'm going to make sure that your primary care doctor, you have a follow-up appointment scheduled with them. If you need to be seen by behavioral health services, I'm going to make sure you have that referral. I'm going to make sure that you have your prescriptions. If we have an in-house pharmacy, I'm going to make sure that you have those filled before you leave the hospital. So you're going to take all of these measures, everything that you can do reasonably to try and lower this readmission rate. So there's been a lot of research done to find out kind of who is at greatest risk of coming back to the hospitals and being readmitted. Disproportionately so, it was the low-income Medicare beneficiaries, right? So the hospitals that were being penalized the most are in the most vulnerable communities as well. There's a lot of words on this slide. So just kind of look at this a little bit. It's just saying most Medicare patients stays, about 78%, are in hospitals with either no penalty or penalties equal to less than 1% of their Medicare inpatient payments. Okay, so if we look at rates of readmission, immediately following the ACA, they're going down. You can see clearly that the rates are going down, and when you tie this to reimbursement of services, you're going to get a change, right? So people will figure out how to not lose money. So you see this shift here. Some issues with the hospital readmission program. So going back to these hospitals that were penalized the most because of who their patient population is that really fair?
No.
No. Why is that not fair?
You really can't control that.
Right, you can't control that. So backing up just a little bit. So when we say higher than average readmission rates, where do they derive those readmission rates from? Previously, they pooled all the hospitals together, okay, regardless of where they were located, what their patient population was. They just pulled all of them together, came up with the average. If your individual average was higher, then you got penalized. But that's not really fair. You're kind of comparing apples and puppies. It doesn't work, right? So, they are creating peer groups, and these peer groups go into effect in 2019. So this is where they're going to take like hospitals by size, organizational structure, location, patient population. They're going to group these hospitals together and form these peer groups. So moving forward, when they come up with their averages, they are going to be compared to the group of peers rather than all hospitals across the nation as a whole. So that should be much more reasonable and a truer reflection of readmission rates for a particular hospital if they have that type of patient population who is more at risk. So you have to keep in mind though that this distribution of the hospitals is also always shifting. So even within your peer group, you may be the top hospital with the lowest readmission rate for 1 year. 3 years later, you find yourself at the bottom and you have penalties, right? So you just have to keep in mind that even within that peer group structure, there's always going to be this movement and redistribution across time. Hospital-acquired conditions or hospital-acquired infections. This is a bit what we were talking about earlier, where you go into the hospital for a particular procedure, you get that procedure, you go home, you end up getting an infection, but that infection was actually a product of being in the hospital the first time. So this is your hospital-acquired condition. And what we're trying to do, just like with readmissions, is we're trying to reduce those hospital-acquired conditions or infections. It's basically the same program. So if you have an excess rate of, I should say, acquired infections, your payment is going to be reduced. This is to foster quality improvement within the hospitals. And from 2010 to 2013, there was a 17% decline in hospital-acquired conditions. And again, all of these programs are funded and implemented under the ACA to control costs. Just want to make sure we're tying everything back to the ACA. All right, so value-based purchasing program. Again, same concept. We have these hospital payments. For achievement, their performance is based on specific benchmarks that they have to meet. We're going to go into the measures for those here in just a minute. And we have to see improvements from their baseline. So they get measured on patient and caregiver-centered experience of care or care coordination. Also safety, clinical care, efficiency, and cost reduction. Medicare is withholding 2% of premiums no matter what. And they redistribute that 2% based on how hospitals perform on these measures. So between the three different programs, they really stand to lose a lot of money if hospitals aren't on board and really proactive with this, right? All right. We're going to take just a couple of minutes. I know we've gone over lots of information thus far, and I've made a couple of notes where it seemed like I had some blank faces and you guys were confused. So, do you guys have any questions about any of the material that we have covered thus far? Really? Nothing? Oh. All right. Well, Well, I'm gonna go back and talk about subsidies for just a second, because that was a whole lot of information at one time. I just wanna clarify a couple things to make sure we're on the same page with the subsidies. So, as part of the ACA, subsidies were offered to insurance companies as an incentive to be part of the insurance place market. Those were short term. I think it was 3 years or something like that. Anyway, so after those subsidies, after those 3 years, those subsidies dropped down a little bit to 90%. And then after that, they just went away. So in 15-16, that's when the subsidies ran out. So that's when you have this problem of the insurance companies pulling out of the marketplace, and we don't have that buy-in anymore because they don't have that incentive by the government to stay in the marketplace. So the effect of this lack of subsidies resulted in premiums going up for some people upwards $500-600 a month, depending on their location. We're gonna really talk about that in detail here in a minute. But so basically, a lot of people were promised things are gonna be okay, you're gonna be able to keep your plans, and then that just wasn't the case because their premiums skyrocketed so much that they couldn't afford it. With that said, have you guys ever heard the adage, don't throw the baby out with the bathwater? Okay, so this one thing didn't go very well, right? That doesn't mean scrap the entire ACA. This means this is something that we need to work on. Maybe we need to find additional funding to reinstate these subsidies, something along those lines. Does that make subsidies any more clear than the first time? Okay, great. Just want to make sure. Okay. So now we're talking back about the Innovation Center. This was established in Section 3201 of the ACA. This was to test innovative and service delivery models. So this is where we talk about state innovation models. They were awarded approximately $960 million to work on these programs. They're evaluating results and best practices and engaging a broad range of stakeholders. So basically, CMS is giving a lot of money to these state incubators, okay, to pull in public payers, private payers, providers, health systems, to figure out how to braid together these funding sources and provide a high quality healthcare. So with the state innovation models, they provide federal grants to states to design and test the innovative state-based multi-payer healthcare delivery payment systems, okay? A lot of them use these funds to kind of crop up ACOs, or accountable care organizations, implement PCMHs, patient-centered medical homes, and implement bundled payments or episodic payments. Have you guys heard of those before? I'm sure you've heard of bundled payments before. Yes? So episodic payments is the same thing as a bundled payment. It's just saying that this type of payment applies to this one episode of care. Okay? So they're giving the money to figure all of this out and then basically say what worked, what didn't work, and how do we take this to a larger scale. So this is the current map of the SIM projects. You see Tennessee is green, which means that we have SIM, and for Tennessee we're primarily focused on your bundled payments or episodic payments. That's just kind of for general reference. So key points for state innovation. It includes public and private stakeholders or payers. We're transitioning to 80% of reimbursement from your FFA to value. It should be FFS, fee for service. And it is currently collectively being evaluated. So even though it's still being evaluated, your subcomponents, we do have data for those. So we are going to go over that. So So here's more about your episodic care or bundled payments. Historically, when you go to the hospital, you may not have noticed this so much now with since the ACA, but previously, say you went to the hospital to have a surgery, you would get a bill from the hospital for your stay. You would get a bill from the radiologist for any x-rays or ultrasounds that you had. You would get a bill from the lab for any blood work that you had. You would get a bill from the physician for their time for being there. This alleviates all of that, and it makes it one single bundled payment across the single episode of care. So this is triggered by a DRG. Do you guys know what a DRG is? Okay, so this is, we're talking about medical coding. So this is a diagnostic related group. So when you go to the hospital and they're working with billing, they assign this DRG number, 586.2. I don't know, I just pulled that one out of the air. But whatever the cost is associated with that DRG number that has been assigned to your care, that basically tells everybody that's going to be involved in that episode of care, you have $27,000 to treat this episode of care. If you can do it, good on you. If you have money left over, you get to keep it. That's great. If you're short, that's your problem, right? So this bundled payment system, if it really incentivizes them to think about how can we decrease costs, and they still have that quality that they have to reach for their benchmarks. So it's not like they can say, oh, well, we'll just cut out this, this, and this, and then we'll be under where we need to be. They can't do that. They have to do both of them simultaneously. So if they end up spending more than the allotted amount of the bundled payment, they have to cover that cost somewhere else. But again, if they spend less, they get to keep it. So current findings. Payments have been reduced in 2 of the 6 categories, and it increased in 1 of the 6 categories. And overall, no difference in quality of care with bundled or episodic payments. So basically, bundled payments have been a wash for the most part. Okay, we are going to do our quick brain break now because the accountable care organization stuff is really, really dense material. And plus it's going to get you guys talking, so I'm excited about that. So we're going to start with the first person in the row. So we're going to start with you. Have you guys heard of the game Telephone before?
Yes.
Yes? No? Okay. So I'm just going to describe it briefly. So when you're in preschool or in kindergarten maybe, yes, this is a young person's game, but we're going to have a lot of fun with it. You sit in this circle, and one person turns to their partner and whispers something in their ear. And that person is supposed to whisper that same thing in the other person's ear. And then you get around to the other side, and it's really interesting what actually comes out. And the last person says, was your comment this? 9 times out of 10, not even close. We're going to do something a little bit different. We're going to tell a story.
Oh.
Yes. Each person gets to make up 1 sentence of the story. So we're going to start with you. It can be on anything. I don't care. This is just for fun to get our brain off of this for right now. And you guys feel free to take it wherever you want. Okay? I'm going to pause the recording so this is recorded. So on to accountable care organizations, or ACOs. So kind of like your bundled payments, this is a similar construct in that this is a group of providers that are sharing collective accountability for cost and quality of services for Medicare patients. So health systems have a lot of providers, right? But over the years, there has been a lot of integration as well, and that's where these ACOs really came about. You have these health systems acquiring a lot of assets. Why are they doing that? Why are hospitals going through, or not necessarily hospitals, but healthcare systems, why are they acquiring a lot of assets? What prompted that? Now you guys just told a really awesome story, and now I get nothing. Come on now. Think about it. What are some things that would prompt these healthcare systems to want to buy up additional assets? So you say you have your hospital, and the hospital goes and they purchase the primary care doctor, and then they go and purchase behavioral health, and then they go and purchase a pharmacy. Why would they be kind of collecting all of these assets? What is in it for them to do that?
ROI,
I'm sorry?
return on investment.
Yes, exactly. Return on investment. There's what makes them think about the ROI? Think about stuff that we've talked about earlier with reimbursement.
Would that improve the efficiency and the quality of the health?
And what does that do?
Increase their profit?
It increases their revenues, right? So it's kind of like this 4 heads is better than one type of thought. It's really a survival mechanism due to these changes in reimbursement. To reach economies of scale, they can leverage negotiating power with insurance companies. They can leverage purchasing power. But while they're doing this, they're simultaneously adding all of these levels of care that aren't necessarily coordinated. So that's a bit of an issue there. There's 2 different tracks. They have the one-sided track and then the 2-sided track. The one-sided track is like your carrot only, okay? And the 2-sided is your carrot and your stick. I'm going to explain these. So with an ACO, these group of providers have an actual contractual agreement to work together to ensure that these Medicare patients are taken care of in an efficient and cost-effective manner. And the whole premise is basically that's their financial incentive, right? So it boosts their revenue. So track 1 is purely the financial incentive. For providing quality care at lower cost, they get to keep whatever funds are extra, right? So same as we just talked about with the bundled payments. The thing with track 2, that's where you kind of have to take the good with the bad. They get to keep extra funds if there's funds left over, but if there aren't funds left over, they're in the deficit, that's what they have to cover. So they can only be on track 1 for 2 years. And then they have to transition to track 2 in the 3rd year. So there is a bit of a buffer, but if you exceed that buffer, then you either earn or lose money depending on your track. Because you're not going to lose money if you're in track 1. You can only gain money. But you have to meet these quality benchmarks in order to get this funding. So the trick here is, what is the risk with this type of arrangement? From the patient perspective. And this is something they're not supposed to do. So
Wait, they're not supposed to? What are they not? I missed part of that.
yeah, okay. So the risk of this type of arrangement from the patient perspective is they're kind of at risk for lower quality of care because the way they're incentivized, these companies are incentivized, they're kind of incentivized to provide lower quality of care so they don't spend money, right? That's why we have the benchmarks in place. That way they don't lower the quality just to be able to make or generate higher revenues. So you have basically three types of ACOs. You have your pioneer ACOs, and these ACOs were the ones that were in place prior to the ACA. So these were the early adopters. They've had previous experience. Then you have your Medicare Shared Savings, or also known as MSSP, Medicare Shared Savings Plan. These are your more traditional adopters who have come into the ACO market since the inception of the ACA. And then you've got your next generation ACOs. This is experienced ACOs taking on more risk or reward. This is your ACO distribution. So the really dark reds is representative of more than 15 ACOs operating. And if you take a look at Tennessee, we do have some ACOs. In East Tennessee, we're kind of limited to the 2. Middle Tennessee, we have 4 to 5 ACOs in operation. But there has been an uptick in the ACO growth. So people are getting together and really trying to figure this whole thing out. Look at the difference there. So this is the first quarter of every year from ACA inception through, oh no, it's 4 quarters, sorry, from 2010 to 2013. So we started out at 41 ACOs, and now we're at just at the end of 4th quarter 2013, all the way up to 600. So there were 12 pioneer ACOs, and so these would be considered your advanced models. These have been around long enough now that there are data that really show how these are working. There used to be about 20 or so ACOs, but some of them realized this wasn't really for them, and so those dissolved and we were left with 12. 8 of those 12 have saved money. 6 saved beyond the minimum and actually earned payments back. 2 saved, but not enough to earn any money back. And 4 lost money, but of those 4, only 1 had to pay money back, right? So this is really a positive trend. You have a net savings of not quite $700,000. So savings is the point, but it's not really the point either, right? There's a bigger, more important issue here. And this is, how things are changing the way that care is organized and delivered in practice. Yes, we want to save money, but if we save money and don't make these substantial changes and how this healthcare is delivered and organized, that's not going to be sustainable, correct? Right. So if this has a positive impact, it would impact the system. Overall, with roughly $700,000 in net savings, is that substantial when you look at the big scheme of things?
No.
No. I mean, that's really not even equatable to the level of dust that's sitting on the ACA right now, right? Okay. So, where was it? Here I said medical shared savings plan, so that's what this MSSP is. So this is the second tier savings plan. There's 392, 202 of those saved money, with 119 saving beyond the minimum where they earned money back, 2 saved but not enough to earn money back, and 189 lost money. So we had a net loss of $216 million. So how does this net savings of $669,000 compare to a net loss of $216 million? Huge difference, right? So yes, we're losing money, but this is an investment, right? It's not something that we're going to get right off the bat. You have to put money on the table for change to happen. So here's kind of the half full, yes?
MSSP.
That was the medical.
Yep. I was going back to try and find the slide, but I think I passed it already. So I can show you. Yeah, Medicare Shared Savings Plan. Yeah. So the first tier would be your Pioneer ACOs, and then your second tier is your MSSP. Okay, so here's kind of your half full, half empty scenario. So these programs are obviously still in their infancy. We are still learning, figuring out what it is exactly that we need to do. Let me rephrase that. We know what we need to do because that is what is in the ACA. It tells us what we need to do, but it doesn't tell us how to do it. So we are still trying to figure out how to do what is needed. Okay, the half full stuff. We are saving money, at least some, in some areas. ACOs are in their infancy and they're still learning. Expanded to scale, savings could add up over time, right? The half empty stuff, the impact or savings is budget dust, really, right? So we had the 700,000, it's not really much compared to the 216 million deficit. And it is a significant investment for a marginal return. So there's a lot of fixed costs involved that aren't even really talked about here. And these fixed costs requires really a robust infrastructure. So the jury is still out on ACOs and really will be for a long time until we have a better handle on how we need to do these things. Patient-centered medical homes. Before we continue, does anybody have questions about ACOs? Yes, ma'am.
Okay, so we do want ACOs?
Well, that's just the thing. We don't know yet. So while there is data that shows ACOs are good in some areas, we're losing money in other areas. So we have to keep continuing and working to adjust those until we get either to a level out point where it's a wash, or we can definitively say we need to scrap this and start over. Still a learning process.
Okay.
Yeah. Any other questions about ACOs before we start with patient-centered medical homes? Okay, great. So the PCMHs are funded directly through the ACA through CMS, right? It's going from, so this is your, how do I want to say this? We're going from care that's poorly coordinated and expensive, okay? We're going from the fee-for-service model with no incentives to control costs and undervalued primary care. So the PCMH general principles are coordination of care, having care teams, increased patient engagement, and population health management. Again, another shameless plug for Dr. Hale's population health management class. So just keep that in your minds. When we say patient engagement, what does that entail? Why do we want patients to be engaged in their own care?
So they know what's going on, and if they understand,
Mhm.
then they can help their own health.
Sure. Yep. Any other thoughts?
Okay, proactive care.
Yep, they're proactive. It's also kind of like an accountability thing, right? If you're part of your care, if you're cognizant of these are things that I need to do to make sure I'm a healthy person, I have gotten some counseling and some education about these things that I can do to improve my health, are they going to go to the doctor more or less? Less, right? Because they're improving their health. If they're going to the doctor less, what happens to things like readmission rates?
They go down.
They go down. So overall cost to the organization goes down when we have healthier people. But to do all of these things, it does take extra money. So here is just a map of the patient-centered medical homes across the nation. These are just kind of initiatives going on around the country. And you'll see that there's a lot of them in East Tennessee. So there are 481 sites across the country, 434 FQHCs. Do we know what FQHCs are? I heard a yes.
Yeah.
What is an FQHC?
Federally qualified health center.
Yes. What is a federally qualified health center?
I guess health centers are like receive funds from the federal government. So
Yes, exactly. Okay, so an FQHC, this is basically your safety net network of clinics across the country that provide care to low-income families regardless of their ability to pay. So they receive this funding from the federal government that tries to help offset their operating costs for providing care to these patients that may not be able to pay for the care that they receive, right? They can still bill private insurances, they can still bill Medicaid, but they cannot refuse care to anyone for their inability to pay. They also utilize a sliding fee scale. So for their patients, it's based on income, what they have to pay for their visit, okay? Is quality of care at FQHCs better or worse than private practice? What do you guys think? I'm sorry?
I think the quality might be worse because costs, if patients use those facilities more,
Mm-hmm.
there will be more costs for things that need to be done.
Mhm.
Overall, it will just not. You're using more than the available resources to
Mhm.
maintain it.
So that is initially everyone's first thought. It was mine as well. There is actually no difference in quality between FQHCs and private care. Now, keep in mind, this is an aggregate form. So this research was done in aggregate. There may be substantial differences in quality for individual clinics, but as a whole, there is not a quality difference between FQHCs and private practice. So roughly 2,100 providers serving about 3 million patients. About a fifth of those are Medicare and Medicaid. There are 38 public-private payers. Results so far, most did well enough for CMS to break even. So, yay. Not quite enough to net savings, but there has been an impact on emergency department visits and hospital readmissions. And we saw that in some of the charts that we looked at earlier. So what are the key points, right? The key points are we need to link payment to quality. This requires a multidisciplinary approach. We have to improve efficiency. And with better outcomes, hopefully these are cost efficient. So fundamentally, we have to shift the way that care is provided or delivered. Any questions about patient-centered medical homes before we go into something new? Nope? Okay. All right. So waste, fraud, and abuse. So the ACA gives CMS more latitude to kind of weed out the waste, fraud, and abuse. Can you think of another instance where there have been initiatives to weed out this waste, fraud, and abuse in other programs besides healthcare? What about welfare or food stamps? Have they done anything with those programs to try and weed out waste, fraud, and abuse?
The drug testing.
Uh-huh. Drug testing. So with this premise, they're basically saying we as taxpayers should not be paying for and providing these needs to people who are on drugs, right? So there's kind of an ethical thing there. You can be on one side or the other, but just looking at the numbers, they're saying we should not be providing this funding, right? So what they did was they initiated this drug testing and said we are going to drug test everybody that is on Tennessee Assistance for Needy Families, which includes the welfare benefits and WIC and food stamps, SNAP, all of that stuff. And anyone who has a positive drug test gets kicked out of the program, and they have to, in some cases, repay back funding that they received. Does this save money?
No,
No. Why does it not save money?
because you're having to pay for people to take drug tests.
So you're paying for all of this in an effort to reduce waste and fraud and abuse. And in the end, you're spending more money and you have a net loss rather than a net gain. So this hasn't really worked out very well for that program. So they're basically saying here that this expands the government's ability to monitor and punish Medicare and Medicaid abusers. Spending is decreased by $2.9 billion, with $900 million in additional revenue. For every $1 invested, it yields a return of $1.75. But that's not always the case. Prevention and wellness. This portion of the ACA does not look like it did originally. There was a lot of cuts to this before it actually got implemented. But the prevention and wellness portion, it added annual wellness visits to Medicare. There was a lot of these councils created, so you have the National Prevention, Health Promotion and Public Health Council, and then you have these funds as well. The National Prevention and Public Health Fund. They have about $616 million to fund public health activities, and they offer grants for evidence-based prevention programs. When you're trying to cut costs in a program, what are typically the first ones to go?
The public health ones.
The preventive ones, right? Because when they're looking to cut funding, they're kind of thinking what is going to make the most difference, right? And for a lot of people, they don't see that preventive care is going to drive a big impact. I respectfully disagree with that. I think if you have healthier people, you start with healthier people, you're going to end up with healthier people. So I am a huge proponent of preventive medicine. So anyway, when they're trying to cut these costs, they cut out all these preventive programs and focus more of those funds on kind of the acute care and chronic conditions. So when it comes to controlling costs, the ACA is costing less than originally anticipated, to the tune of $2.5 trillion less than what was expected. Now, some of this can be attributed to the state mandate not being implemented, so some states did not opt to expand their Medicaid, so there was a substantial savings there. Healthcare costs are still growing, but it's at a rate of growth lower than expected. Is there ever a point where healthcare costs will either remain static or start decreasing? Nope. Healthcare costs are always going to go up, right? But they're going up slower than what we had anticipated. The growth of healthcare costs is actually at a 50-year low, being at roughly 4%. So why did this happen? Is this a result of the ACA? Is it a result of the recession, 10-ish years ago? Maybe a combination of both of them. We're not saying that all of this trend can be attributed to the ACA. There are other external factors, but a portion of it definitely could be attributed to the ACA. So just to kind of, again, put this in pictures for you visual learners. So the vertical black line there is the ACA, right? So this is what it looks like. The recession is that low dip you have there around 2008-ish. Then you have implementation of the ACA. So despite extending coverage to over 20 million people, the healthcare expenditure growth is lower than it was leading up to the ACA, I think that's a pretty significant achievement. What is the primary criticism of the ACA in the public domain? Think about the economy. What did a lot of people think the ACA was going to do to the economy? Did they think it was going to help the economy, or did they think it was going to kill the economy? They thought it was going to kill the economy. What does this graph say? Yeah, I mean it's definitely not the case. It is not killing the economy at all. And again, some of this could be attributed to the recession, but it could also be attributed to the ACA as well. The cost of healthcare is always going to increase, and you know that's kind of the big shtick with people. They say, "Oh, well, we still have these healthcare costs that are rising." Yes, and that is always going to happen, regardless of what type of healthcare reform we have in place, right? But it's growing so much slower than it was, and that's really where the difference lies. So this is just kind of a different ways to look at their funding sources. So here's the where the Affordable Care Act did some spending cuts. Just kind of take a look at that and real quick. Same thing here, ACA revenue increases by type. Okay, so key issues here. Stability of the insurance marketplace. The premium stabilizers are gone, right? The premiums are going up significantly for those who bought premiums through the marketplace initially, because we've got those subsidies that stabilize the insurance market. Those are gone now. With repeal or replace, we have the uninsured and uncompensated care costs to providers. I'm going to talk about that here in just a bit. So the difference in premiums Americans pay for the second lowest cost silver plan from 2014 to 2015 before your tax credits. So we're looking at increase in premiums nationwide. The dark orange represents a double-digit % increase in premiums. Double digits. Where is East Tennessee? Not geographically speaking, obviously. Yeah, exactly. So East Tennessee is part of that double-digit premium increase. This is due partly increase to Tennessee not expanding their Medicaid. On the flip side, you have this dark blue. There's actually some counties that are going to have a double-digit decrease in their premiums. So why? What is the difference? So we look at the silver premium % change from the previous year. So in states that expanded their Medicaid, the average increase in premium is 7%. Okay, 7%. So why would Medicaid expansion help keep premiums down for private insurance? And we've touched on this topic a couple different times so far today. Think about the populations that are served. Why would Medicaid expansion help keep premiums down for private insurance?
Because there's more low-income individuals,
So if Medicaid is expanded,
and you have more people covered.
you have more people covered. So you have your lower risk pool in your private insurance, and because they're lower risk, they don't have as high premiums, right? So you have a lot of these low income people who are typically sicker. In expanded states, those people are able to get covered. In states that did not expand, they can't get covered, so that drives the risk pool up, driving premiums up in your private care. So the cost is shifted to the private insurance, and they shift the cost to the people who buy the insurance. So the point is, we are always paying for the uninsured whether you realize it or not. It's just in a different way. It's just packaged differently. So, you whether it's taxes or premiums or whatever, same thing, just a different package. All right, so key issues. Insurance company participation. From 2014 to 2016, there were roughly 7 insurers per state. 2018, roughly 5 insurers per state. So why are insurance companies pulling out of the market? And this is actually why I went back and talked about this a second time.
Subsidies.
Right, because the subsidies were gone. They no longer have that financial incentive from the government for them to cover these higher risk pools, right? With repeal or replace, you have your uninsured, uncompensated care costs to providers, you have hospitals, providers, insurance companies. So all of these increase with the repeal and replace, right? But that got taken care of, so we don't have to worry about that at the present moment. So this one is the first quarter of every year since the APA. It's the individual market medical loss ratios. So when the premium stabilizers ran out, which was your subsidies that were provided to your insurance companies so that they would, to get their buy-in to participate in the market, it had this big impact on your insurance companies when they lost these subsidies, so they started losing money, right? So about 88 cents on the dollar went towards paying these claims. The medical loss ratio has now settled out. So this 88 cents or 88% here is your quarter 1 of 2015. That's with the subsidies in place. 2016 dropped to 86, so that would be 86 cents on the dollar we're going towards claims. Quarter 1 of 2017, it's at 75. That has now kind of stabilized, so they're not losing money anymore. So yes, premiums did go up on the marketplace, but now we're kind of seeing this stabilization. And then you have your average first quarter individual market monthly premiums. The average premium versus the average claim per person, you can see that they're not losing money anymore. So now that things have settled out, evidence suggests that the market is stabilizing and they're not going to see a substantial increase in premiums, at least while the market is still stable. So uncompensated care costs. This goes to, remember when we were talking about the hospitals or FQHCs where they could not turn away patients for their inability to pay for care. So that is what uncompensated care is. It's where someone is provided care and they are not able to pay for it, right? So this fell from 3.9% to 2.3%. With the Medicaid expansion, we saw a 60 to 70% reduction. If all states were to fully expand Medicaid, that would result in $8.9 billion of saved revenue. That's a substantial number. If we repeal this, hospitals, low-income communities, they're going to take the hit, right? Yeah. So the health providers are being reimbursed for things that they didn't used to be reimbursed for. Okay, healthcare reform expanded insurance to 16.9 million people, roughly 17 million people. We've had modest growth, regardless of the reason. And basically, the wheels didn't fall off the wagon. Yes, there were things about the ACA that did not work. They need to be looked at, reassessed, revamped, implemented again, piloted. But if you look at the macro level and look at the net gains and losses, arguably coverage was expanded and there's not been too much of a consequence paid. So I want to point out the importance of perception here. When if I were to go up to someone and say, what are your thoughts about Obamacare? Depending on the location, they're going to be fairly negative. And a lot of that has to do with the perception of Obamacare, right? If I were to go to that same person and say, what do you think about denying coverage for pre-existing conditions? They're going to say, well, that's horrible. We shouldn't do that. Well, what do you think about putting lifetime limits on the amount that insurance can pay for you? They're going to say, oh, well, that's horrible. We shouldn't do that either. Well, do you think that we should not allow students or people under the age of 26 to remain on their parents' health care? No, of course they should be. Well, should we deny pregnant women from coverage if they aren't currently insured? Well, no, of course not. Those are all individual elements of the ACA or Obamacare, but the perception is entirely different because it's more on that personal level for them. You're not any longer talking to them about a policy or a program. You're talking to them in language that means something to them. So I just want to reiterate that you know, it's there's a lot of this is about perception as well. You know, people are mincing words. So I just think that's kind of interesting. Next week, you guys are going to have a chat about law and ethics, I think. Does that sound right? Yeah. So Dr. Beatty will be here for that. The following week, it will be me with quality improvement. I'm so excited about that, by the way. It's kind of my thing. Do you guys have any questions? If you want to go back through your slides, look at anything that you have any questions about or you aren't clear about something, just kind of take 5-10 minutes and review those slides and see if you have any questions, and then we're gonna go over just a couple more things, okay? All right, so go ahead and take your 10 minutes to review and think of any questions you may have. Okay, so now we're gonna do a little bit, oh wow, that is blinding. There we go, that's better. We're going to do a little bit of an exercise to kind of reinforce everything that we went over today. I have the attendance sheet, so I'm going to call you up one by one. So we have some things up here divided into different sections. So you have ACA policies. So really when I said that I wanted you guys to look at your slides, I literally meant look at your slides. So we're going to go over 3 different categories just to basically give you a really brief synopsis of the lecture today. We're going to go over ACA policies, healthcare reform, and payment and delivery models. Okay? So what you're going to do when I call on you, and I'll let you know which section we're going to do, and we're not going to do all of them in order. And we're also not going to fill in an entire section at one time. We're going to go back and forth. So I can be really, really confusing. So you're going to come in up here and say, I said we're going to do a payment delivery model. I'm going to have you list one of those payment delivery models, and you're going to tell me 1 or 2 things about that particular model that we went over today. Okay? Just something that you think is really important. And then we'll see if anyone has any questions, and that way I can clarify anything if someone needs it. Okay? Perfect. And you guys are like, I can't believe she's making me do this. Okay. Okay, if you don't have fun doing this, please do not let it reflect on Dr. Beatty's SAIs. Okay. Corey Dillard. Ironic that I picked the redhead on the first try. Okay, so we are going to talk about ACA policies. So there were two different types of policies that we talked about today. What was one of them?
Insurance marketplace reforms.
Yes, what is that meant to do?
Um,
So I should specify, there are two different policy aims. What were those what is,
medic,
nope. What is the insurance market reforms aimed at doing? Increasing what?
access.
Yes, yes. So we are wanting to create access.
Okay.
So go ahead and write that down under ACA policies. And you already listed one of those things, which was the insurance marketplace reforms. But what was the other thing to create access? One more policy change that not necessarily applied to everyone. It was supposed to originally. Expansion of what? Yes.
Is that what you said?
Yes, so but those were the two things. So the policies were to create access, and the two policies were insurance market reforms and Medicaid expansion. What was unique about Medicaid expansion?
It was the state's choice.
It was the state's choice. Was it originally supposed to be the state's choice? No, it was originally mandated. Thank you so much, Corey. I appreciate it. I promise I was not picking on you.
No, you weren't.
Okay, Lauren Hooper. Okay, we are going to do, let's do payment and delivery models. What was one of the payment and delivery models implemented by the ACA? There were 4. Some of these, so there's a lot of acronyms.
Right.
One of them we went over in a lot of detail. It would be.
Can't you phone a friend?
Yeah, really? No. So what about the acronym ACO? What does that stand for?
They're like,
What type of care? Let's help her out. What is ACO?
accountable care.
Yes. So go ahead and write that for number 1. We're going to talk about ACOs. So tell me one thing that you remember about accountable care organizations from today. There was a whole lot about ACOs, I know. Tell us one thing that you remember about ACOs.
It's a payment and delivery model.
Yes, it is. So the biggest premise of your ACOs is it that we have a bunch of these individual entities, or is it a group collectively sharing responsibility? Yes. Yes,
Do you want
it
to write,
is.
is that a right thing? Is that
No.
right?
Yep, you can go ahead. Thank you very much, Lauren. Does anyone have any questions about ACOs? Because that was like a huge section, I know.
Does the wording matter, like, for the ACA that much?
What do you mean?
Like, for the perspective redesign, like, I know the ACOs had to be at least 1,500 words. Is that like a?
Oh, no.
Okay.
No. So what we were saying about with the word stuff, basically that was saying all of these people that were saying that this program is going to be so onerous, why would we vote for this? Who's going to read all of this? It wasn't that long of a policy to read. It was, a third of a page. That was just the word thing. Yeah. So does anyone have any other questions about ACOs? No, okay. All right, let's see. Braden Sexton? See, this is fun because I'm learning all your names now. It's fun for me. You guys are like, no. All right, we're gonna do, I can't read my handwriting, healthcare reform, I think. It's also on a slant, so I can't read it. Okay, so there were, basically 4 main types of healthcare reform. What was one of those? So we had something, with employers, we had something with individuals. Medicaid expansion, yes, absolutely. So tell us something that you remember about Medicaid expansion from today.
Increase access.
Because that was one of the reforms under creating access, which is the 2 policies for the ACA. Why was it decided that the states could opt out of Medicaid expansion? So basically,
Tennessee did.
yes, they did not. And basically it was because it was a cost issue, right? So the Supreme Court decided that this would create too much of an undue burden on the states. So we're going to say that states have the option to expand Medicaid, but they're not going to be required to do it. Yes, thank you very much. Aaliyah Spalding? Alrighty. Yes, ma'am.
If we had the budget for Medicaid expansion, then why was the cost an issue?
That is a very good question, and I don't know that I am well informed enough to answer that for you. That would likely be a better question for Dr. Hale. You are more than welcome to ask him that because I don't understand that either. Totally important as an instructor, guys, if any of you want to go in academia. If someone asks you a question you don't know, don't say that you know it and make up some cockamamie answer, okay? Just be like, I don't know, but I can find that out for you, or I can point you in the right direction to find that out. Totally adds to credibility. Okay, we're gonna go back to payment and delivery models. So what's one of the other 4?
Pay for performance.
Yes, pay for performance. So tell me something that you learned about pay for performance today.
I didn't know about the hospital readmissions thing at all.
Okay, exactly. So the pay for performance thing or value-based purchasing, kind of all one and the same. It had all of these different moving facets, right? So what was the biggest shift with pay for performance? We went from what to this? It's another acronym.
Fee for service?
Yes, fee for service. So traditionally, we were organizations were being reimbursed based on simply providing a service. That's not it anymore. Instead of charging a fee for a service that they provide, they're getting paid based on the quality of that service. So how well they performed. Very good. Michaela Bowers. If I butcher any of your names, I apologize ahead of time. Okay, we're gonna go back to healthcare reforms. What's another one of the healthcare reforms that were part of the ACA policies?
Individual mandate.
Individual mandate. Tell us about the individual mandate.
If you didn't get insurance, you had to pay unless you followed underneath.
Yeah, so it's kind of one of those things, if you don't do this, you have to pay unless you don't. Like what? Yeah, so even though you're supposed to pay based on the individual mandate, if you don't have insurance, there are exemptions to this. Can someone name what one of the exemptions are?
No income.
No income? Yep.
Homeless?
Homeless? So if you're homeless, do you file taxes? No. So there's a whole bunch of exemptions to keep in mind for this as well. Okay. Henry, I'm not even going to try your last name. Is it Amisa?
Yes, right?
Baby! Guys, when I worked in biology, here on campus for 7 years, and I was over the graduate students. And of course, I would get all of these international graduate students. Y'all, I would butcher their names so bad, and I felt horrible, absolutely horrible. Okay, we are going to go back to payment delivery models. So we've got two listed: accountable care organizations and pay for performance. So what is one of the last two of the payment delivery models that were part of the ACA?
I'm gonna say state innovation. It's about like federal grants.
Yep, so State Innovation Model, or called SIM for short. Who are the state innovation models funded by? I mean, the ACA, yes, but who controls them?
CMS.
The CMS, that's correct. So, for state innovation models, what, you said it provided grants to states,
Yeah.
but what was that grant funding for?
Is this for the incubators?
Mhm.
Okay.
Yep, so this is for the state incubators, right? So this is to provide funding for states to figure out how we need to do what we need to do. Exactly, thank you so much.
So
Okay. Heather Diebold. All right, healthcare reform. What's another one of the healthcare reforms?
Employer sponsored health insurance?
Yes. So tell me a little bit about the employer-sponsored health insurance.
So if you have 50 or more employees, you have to offer health insurance.
That is correct. Very good. Can anybody else tell me anything else about the employee-sponsored health insurance? Anything else that you learned today about that?
Crowd out.
Right. So when employers, with this mandate, there were some employers who opted to either cut positions or cut positions entirely or cut them down to part-time and reduce benefits. This caused crowd out. And what is crowd out?
It's when they push them to Medicaid.
Right. Yep, so they're pushed to Medicaid. Exactly. So you have this influx of Medicaid recipients. Okay. Summer Jackson. What is our last payment delivery model?
What have we got up here?
We've done ACOs, pay for performance, and your state innovation model or SIM.
Patient-centered medical homes.
Yes. What is that?
So can I just put CMH?
PCMH?
Yeah.
Yep, you sure can.
So it kind of focused on that the primary care is undervalued and that care should be coordinated.
And what does coordination of care mean?
Like the pharmacists and the doctors and the social workers are all coordinating together.
Yeah, so it's this collaborative environment to provide best possible patient care that is both high in quality and low in cost. Yes. Very good. Okay. So the PCMH model, what is that related to for you guys? Course study wise. Population health management. Take Dr. Hale's class. It's the third time I've said it. Okay. Okay, yes, so coordination of care, you have these care teams. The other thing is patient engagement. And why is patient engagement important? Guys,
So we don't have to
I'm sorry?
Better outcomes.
Yes, better health outcomes. Great. Okay. Brianna Gorski, I think.
She left.
Oh, well, that's unfortunate. Okay. Ooh. I'm totally going to guess here. Fasayo? Usayo. I was so close. Okay. Alright, so you are going to address the second ACA policies that we were talking about. Yep, so control cost. That's what the second set of policies were meant to do. And to control these costs, what reform, type of reform was it? So the two things that kind of go into reducing costs. So reducing costs, we have to address both payments and practice. So those are the two types of reforms influenced by that policy.
So that's the policy, the payment and practice.
That's correct. Yep, great, thank you so much. All right, last one. Carl Oberfighting.
He also left.
Oh, well, who? And I tried so hard on his last name too. All right, I'm gonna end on an easy one. Hannah Henson. Thanks, girl. All right, so for healthcare reform, we have Medicaid expansion, individual mandate, employer-sponsored health insurance. What is the remaining reform that we haven't talked about yet?
Is it, Medicaid extension, is it that you could stay on your parents' insurance? Or no, or is that like a sub?
Yeah, that's kind of a sub thing. So, it's health insurance. What?
Exchange?
Yes, health insurance exchanges. Tell me about the health insurance exchanges.
You can stay on your parents' insurance till you're 20.
Well, that's one of the things addressed in the ACA. But what were the exchanges meant to do?
Lower cost.
What are the health insurance exchanges?
Marketplace?
The marketplace. Yeah. So tell me about the marketplace.
So you can go in and you can purchase insurance if you don't have it.
Mm-hmm.
And there's, what is it, gold, silver, and bronze?
Yes. Exactly. Good job. So, and this was the other thing I wanted to bring up about the health insurance exchanges again, because it's important, because it really influenced how things went moving forward. What was provided to insurance companies as a financial incentive to get them to buy into the marketplace?
Subsidies.
Subsidies. Yes. Awesome. What happened with the subsidies?
They went away.
They went away, and what happened?
And the market collapsed.
Yes, a lot of the health insurance companies said, peace out, y'all. We cannot do this anymore. We aren't making any money. Right? Okay. You guys have been awesome. Is there any questions? Was this helpful to kind of go back over things and highlight key points from today's lecture?
Yes.
Okay, great. Do you have have any questions for me before we conclude for the day? Great.
I have a question